All right, so we are on. Good evening. It is September 9th, Wednesday, 7 p.m. This is our diabetes program Wednesday wellness webinar. I'm going to share my screen so everyone can see what we are looking at. All right, so if you have any issues, anyone from our team or anyone from the audience, you can write your questions in the question box. If there are any questions that you would like to ask directly, you can use the hand raise function of GoToWebinar, and then we'll be unmuting those lines. So we'll be starting our session right now. So this is the United Medical Wellness Program, and then the team, myself, I'm Kamal Erkan, I'm the chairman of the ACO. And I have Dana Gankol, she's the Director of Clinical Integration at United Medical ACO. Now, tonight he's not with us, but our Program Director is Dr. Ripu Handal, and also our lead dietitian for the program is Amy Wilcoxon, and she's also here with us tonight. So, Amy, if you would like to take over from here.
Okay, so welcome to our Wellness Wednesday. Twice a month, we're talking about diabetes and how it affects your life. So we've talked about diabetes as a diagnosis, we've talked about nutrition, and tonight we're going to be talking about two very important parts of diabetes: foot and eye care. And not everyone with diabetes realizes that they should be having regular foot and eye exams. So we do have two specialists to talk with those about those topics tonight. So first we have with us Dr. Ciavarelli. I hope I'm saying your name correctly too. I was practicing all day. Did I get it right?
Yeah.
Brandywine Podiatry, and I appreciate you coming to talk to us tonight. And she is our first speaker on the importance of diabetes and foot care.
Hi. Well, thank you so much for inviting me to be here. It is so important for us to get the word out about why it is important to care for your feet, particularly as a diabetic. Obviously, it's important for everybody, but they kind of get forgotten because they're sort of at the end of the body and you don't really think about them so much. So tonight I'm going to be talking fairly briefly about some of the ways that diabetes affects the feet and why it is important to get diabetic care. I'm going to do that in a way of talking about some of the body systems that are affected and how they are affected by diabetes, particularly in your feet. So who's at risk? So in general, for developing diabetes, people who are overweight, people who are greater than 45 years old or have a family history have a higher risk of developing diabetes. Now, I'm sure that you guys have done lots of education already on who is more likely to develop diabetes. People are more likely to develop diabetic complications, so problems with their feet, are people who have had really two risk factors. The first risk factor is time, and the second risk factor is blood sugar. So the higher your blood sugar for the longer amount of time, the more complications that you have a risk of developing. When you go to the podiatrist, there's going to be multiple systems that your podiatrist is going to look at. And the reason why they're looking is because these are some of the systems that are affected most in your feet by diabetes. I have three of them here: the nervous system, the circulation system, and the immune system. So before we move on to talk about each one of those, I'd like to just break down a little bit some of the things that are going to happen when you go to see a podiatrist as a diabetic. Incidentally, the American Diabetes Association, could you go back to the other slide?
Sure.
Thanks. The American Diabetes Association recommends that all diabetics see a podiatrist at least once a year. If you're diagnosed with any problems, so circulation problems or nervous system problems like neuropathy, we'll talk about that, then you should probably be seeing your podiatrist at least twice a year, and sometimes up to 3 or 4 times a year, depending on what's going on, just for preventative care. But we'll talk about that a little bit more. When you do go to see the podiatrist is going to obviously ask you to take your socks and your shoes off so that they can take a really good look at your feet. And we're really looking at several different areas. So the first thing that we're going to look at is we're going to probably just look at the skin. And I didn't pull that out as one of the systems that's often affected because some of those photos are not so great to look at. So let's just kind of talk about that. They're going to be looking at the skin to see what the texture of the skin is like. Is the skin healthy? Are there any ulcers? Are there any problems? The second thing we're going to look at is the nervous system. And this we're going to talk about in a little bit more detail. But they're going to do an exam of the nervous system to see if you've lost any of the feeling in your feet. And again, we're going to talk about that a little bit more when we go into the nervous system. They're also going to feel for your pulses. Yes, there are pulses in your feet. There's 2 of them, or there should be. And we're looking to see if you have any changes. And then as far as the immune system is concerned, so the way your body fights infection, we're obviously going to look to see if there's any infections or anything that are going on that need to be addressed. Okay, can we see the next slide? So this is an X-ray of a foot. I think a lot of people will be able to recognize that there is an ankle joint there, and then the rest of it looks kind of mushed up. This is one of the most severe complications, and I wanted to show it to you because it's something that just kind of illustrates how people with diabetes can be relatively fine and then have a problem.
Sorry, normally I would wait until the end, but this picture for non-clinicians means nothing. So help me to identify when you say there's an ankle joint.
Sure, sure. That's the ankle joint right in there. No. So you're going to take that and you're going to just rotate it up about 25 degrees.
Rotate up to like here.
Yeah, there you go. There. Well, okay, we'll call that. Yeah, that's generally in the area.
But this area that now, because it doesn't.
That's a great point.
Like you are saying that this is an abnormal foot.
This is an abnormal foot. Yep.
Yeah.
Yeah. And this foot has something called Charcot. Charcot is a very serious complication that can happen with people with diabetes. The reason why I wanted to use this slide to illustrate is that Charcot is one of the things that can happen sort of out of the blue. And that's one of the important things about when we're talking to diabetics about getting preventative care, is that it allows them to have a relationship with a podiatrist who's keeping an eye on them and making sure nothing's going on, so that if anything really bad happens like this, they're going to have a podiatrist that they can go to, and they can get a lot of preventative care. All right, can we get the next slide? Okay, so the nervous system. The nervous system we talked about briefly in the introduction part. The nervous system is one of the most important systems in diabetics that's affected by, in the feet, that's affected by diabetes. There's really 3 different ways that the nervous system is affected. The first is something called neuropathy or sensory neuropathy. And what that means is, that means that you may not be able to feel the bottom of your feet or the top of your feet. Well, you may say, well, what do I care? I don't need to feel my feet. You do. If you were to step on something that was sharp or have a blister, your pain is really important in the body. It tells us, hey, look over here, there's a problem. So if you've developed some sensory neuropathy or some loss of feeling, you may have a problem and not know it. Motor neuropathy is the loss of some of the function of the feet. So some people can develop drop foot and other problems that we're going to look very carefully for. And the third is autonomic neuropathy. And without getting into too much boring detail, really what that's about is about the sweating of the feet and the way that the skin interacts with the nervous system. Can we get the next slide? All right, the next system that often has problems with diabetics in their feet is the circulation system. So as you may remember, you have blood in your heart that has oxygen in it. The arteries bring it down to the feet and the veins bring it back up. And unfortunately, both of those systems can be affected with diabetes. The first are your arteries. What we look for is something called peripheral arterial disease. That's most often, you can see the guy there holding his leg, he's maybe having a cramp. And the venous system, you can see lots of swelling and things like that. So those are signs that you may be having some problems with either the arteries or the veins in the circulation system. Can you get the next slide?
Yep.
All right, so we'll go really quickly because I know this one isn't so great. The immune system is also affected by diabetes. And in particular in the feet, this is the thing that is sort of the most dangerous, is that when you have, say, problems feeling your feet and maybe not great blood flow, and you get a wound, your immune system is going to have an even more difficult time than it would for most other people to affect that and to deal with the infection. So it's very important if you do see any infection. So signs of infection would be redness, swelling, pus, bad smell. Any of those things are an emergency, and you want to go right to your podiatrist. Can we get the next slide? All right, so that's all the bad stuff. Here's the great part, is that for the most part, most diabetics can do a couple of pretty simple things to keep themselves out of big trouble when it comes to their feet. The first thing, keep your blood sugar low. I know everybody says that all the time. It's that important. The second thing you can do is to visit your podiatrist and have an evaluation to make sure you know if you have some of these problems, what can you do? One of the most, like I said, one of the most common complications is that neuropathy where you can't feel your feet. And the good news is you can really stay out of trouble if you have neuropathy by doing two really simple things. The first one is wearing shoes all the time. And that means inside of the house, outside of the house, go get the mail, on the beach. You need to be protecting yourself all the time. You could step on something and not even know it. And the second easy thing that you can do to prevent any kind of problems in the feet as a diabetic is to look at your feet every day. I like to encourage my patients to put a cream on their feet. I don't really care that much about what cream it is, but I want you to have a conversation with your feet. Take a look at them, see what they're doing, see if you see any blisters or sores or anything along those lines. If you do, call a podiatrist, or if it's really, really important, go get urgent care. These things can go from bad to worse in a pretty quick time. Lastly, just a couple of grim statistics that nobody wants to get to. So this is to encourage you to really care for your feet. About half of all ulcerations that happen in diabetics, so ulcers that happen in the feet, end up with a lower limb amputation. Somebody who has a lower limb amputation, so a foot, a toe, half a leg, these kinds of amputations, they have a 5-year survival rate about that of somebody who has pancreatic cancer. So what I'm saying is, don't get wounds. If you get a wound, really take care of it. Try to avoid going down this path. There's a lot of ways to do it, and I know that you're a part of this wellness group, and this is a great first step. And you definitely want to avoid being one of the people who has to deal with this kind of thing, because it's certainly not something you want to go with. And I think that's about it. I think I covered the prevention and exercise. I think I didn't talk about exercise. Obviously, that's really important.
So, Dr. Ciavarelli, this is your group, right? So now, when I was actually looking at the PowerPoint earlier, I think it was yesterday, Don, and we were just going back and forth with some. I had a difficulty to go through the old pictures. Now, in the last one, where the patient is when they lose their feet or foot, so getting to that point, you know, like who does the surgery? How often do you see these? And I know you mentioned prevention is the main factor here, but do you, like, how often in your day, like, how often do you see these issues?
Unfortunately, Kamal, far too often. Unfortunately, for the most part, the vast majority of patients are, you know, really doing everything that they can, and even the ones that are doing all the things that they can, sometimes A small blister can turn into infection, and infection can turn into an ulcer, and unfortunately, ulcers eventually can turn to amputations. So it's an unfortunate part of what we do. It's never something that we look forward to. It's always a really difficult situation. But like I said before, I mean, the great news is that really, you know, an ounce of prevention here really is worth a pound of cure.
Well, thank you so much. So we are going to go to Dr. Hosmane for the diabetes and the eye. So Dr. Hosmane, you are on.
All right, good evening, everybody.
Well, can I just say one thing? So Dr. Hosmane also is my eye doctor, and she's and I haven't. I mean, my first time I think was 2 years ago.
Yes, 2 or 3. Yeah.
It made it so clear to me how important it is to have the eye exam. And mine wasn't the diabetes, but mine was just a regular checkup. And I think I learned a lot, and thank you for that. And I did follow up on my annual check. And it's one of the best experiences that I had in the clinical setting. And thank you for that.
You're welcome. So, you know, why is this so important? Diabetes is actually the leading cause of vision loss in people from 18 to 64. So it's a big thing. And, you know, unfortunately, a lot of folks will not come in for eye exams in general unless they really are pushed to do it. You know, if it's blurred vision or something has to be wrong for them to come in. But especially folks that are diabetic, you know, as Dr. Ciavarelli was saying, our standard of care also is that we want to see people once a year, and not just for the eye exam, because eye exam, there's so many components to it, but specifically an eye exam that includes the dilation. So what is a dilation? So a dilation is when we put some drops in, eye drops in, and that allows us to open up the pupil temporarily for a few hours. And that helps me to see more of the back of the eye. You know, I get asked a lot, well, do I have to have it done, or why should I have it done? Simply, I can't see a lot of the back of the eye if I don't put some drops in, specifically the peripheral part of the retina. So it's really, really important. You know, of course, it's only one component of keeping your eyes healthy. You know, I see folks once a year. Sometimes I do see them more often, depending on what's going on with their eyes. But, you know, it really also comes down to control. If you have other conditions, you know, high blood pressure, high cholesterol, you want to make sure you wear sunglasses. You know, smoking is a big factor, of course, as well. And I know Amy, I'm sure, has talked a lot about, you know, nutrition, what's important as far as nutrition, everything that's good for us anyway. I always like to tell my patients, you know, healthy body equals healthy eyes. So if we are good about our nutrition, you know, the eye health will follow as well. So fruits, vegetables, antioxidants, you know, lutein, things like that. Next slide, please. Okay, so just a little bit of an overview so that, you know, we kind of have an idea of how everything is connected with the eye. So, you know, we're going to talk about the lens in the eye that helps to bring light to the back of the eye. And, you know, it helps us to focus. And we are also going to talk about the retina, which is that back wall of the eye. So, you know, when we have an increased level of blood sugar, there are various areas of the eye that can be affected. So we take a look from front all the way to the back to kind of, you know, check all these components out. Next slide, please. So this will just show you, you know, what an eye can look like. And this is what's called retinopathy. So you have different types of retinopathy. This is diabetic retinopathy. And, you know, the picture on the right is showing you, you know, some effects of what happens when there's increased blood sugar, which damages the blood vessels. And you can have things like leakage and swelling, and, you know, some, you know, blood vessels growing there that shouldn't be there. And, you know, sometimes you can have someone that has high blood pressure as well that can also have retinopathy from high blood pressure. So sometimes you can have two types of retinopathy happening at the same time. But, you know, you have a normal eye, and then that's what an eye, you know, can look like when there is retinopathy. Next slide, please. So, you know, unfortunately, when you have diabetes, that also puts you at a greater risk for other things happening. So we do have cataracts, and we have glaucoma. So a cataract is when that lens inside our eye becomes a little bit clouded. So when we have that increased level of blood sugar, unfortunately, it enters the lens and makes this lens swell up. And that can actually cause a change to your vision. So I've had patients where, their vision is very, very blurry all of a sudden, and they don't know what's going on. And, it's kind of like a telltale sign of, well, there might be something going on, along with other symptoms that they may have. So, it's important that, you do wear sunglasses, you control the blood sugar, because if we don't do those things, we get cataracts earlier and they're going to grow more quickly, as well. So for glaucoma, that's a condition where it can have an impact on the eye pressure. And then we have damage to the optic nerve. The optic nerve is what connects the eyeball, to the brain. It's like that little tail coming out. So it kind of collects all the information from the retina and sends it back to the brain. So, those that have diabetes are at increased risk for having glaucoma. And, the scary part is if you do have glaucoma, you don't necessarily see any different or feel anything different. So this is why when we do the eye exam, we always measure someone's eye pressure to see what's going on, to make sure that it's running at within a normal level. Next slide, please. So, when we say retinopathy, what is retinopathy? So, as I briefly mentioned before, it's damage to the blood vessels that are in that retina, the back wall of the eye. You can have different changes, as we mentioned before, you can have some swelling, some leakage, and sometimes you have these new blood vessels that grow that are very fragile, and if they break, you can actually have a hemorrhage in the back of the eye. And as I said before, it is actually one of the leading causes of vision loss and blindness. It's interesting because sometimes you can have retinopathy and actually not have any symptoms or see anything different. So a lot of times folks don't think that, we need to check for it or, that they need to come in to be checked. But, you can have things going on and we don't know that there's something there unless we, take a look at it. Okay, next slide. So again, some of the symptoms that you may have, you might not have any symptoms actually, but the greater the amount of retinopathy there, of course, the more you're going to notice. So you can have blurred vision, you can have missing pieces of vision, you can have flashes of light, floating spots, and then of course the most severe stage would be just blindness, where most of the retina has been affected. Next slide. So, we know there are different types of diabetes, type 1 and type 2, depending on, whether someone, the body can't make insulin or whether it's insulin resistant. But, basically what we know is the longer you have something, the more the risk becomes. So I always tell my patients, once you hit about that 15-year mark or so, there's probably going to be something back there. Even if your control is really good, we're going to start to see some little changes back there, and I like to make sure that anyone that's newly diagnosed, they really should have a dilated eye exam, within about the first 5 years after diagnosis. So again, about within 5 years or at about that 5-year mark from diagnosis, we can start seeing some changes there, potentially. Next slide. So, is there something we can do about retinopathy? So, it depends on what's there. So if I see somebody and they have just a little bit of very mild retinopathy, I can even monitor their vision even yearly, so basically the more that's going on, the more often I need to see them. But sometimes, depending on what's going on, I have to send them to the retinal specialist, and the retinal specialist has to intervene by doing, things like an injection, or a type of laser. And the whole idea is we can't necessarily reverse the damage, but sometimes we have to try to protect the retina that's still there. So, the lasers and the injections help to stop these leaky blood vessels. And then, sometimes they actually block a protein, which stops these blood vessels from growing. So, that works, but at the same time, the downside is sometimes these lasers will also tend to damage healthy retina at the same time, which has its own, implications. But the good news is if we can work on our diet, when we exercise and we take care of ourselves, then sometimes the retinopathy actually can improve, and it can actually get better. So when I have patients come in to see me, I always like to kind of quiz them a little bit and say, hey, what's your control like? Are you taking your medications? What's your A1C? Tell me what your fasting blood sugar is like, so that we have an idea and they have an idea of what their control is. I think, unfortunately, because of everything going on with COVID, it sometimes has affected patients' lifestyles. They've been more sedentary. They've not been as motivated to do things. So I've had a lot of patients that have said, what, I kind of fell off the bandwagon a little bit, and I'm trying to get myself back on track. So we kind of have to work together and kind of help them to get back on track to work on their care. Next slide. So you can also have something called macular edema. So the macula is the center part of our vision. So if that area is affected and you have some swelling there, you're going to definitely have some changes to the center part of your vision. So anything from a little smudge in the vision to just kind of a dark spot in the middle of the vision, depending on how much swelling and then sometimes ultimately leakage you have in that area. Again, that can be treated. You can do injections a lot of times, some lasers, and again, this would warrant referral to a specialist. Again, sometimes when you have these new blood vessels that grow, they kind of tend to pull on things and they kind of tug on the retina sometimes. And unfortunately, what that results in is an actual detachment of the retina. So that's really an emergency, obviously. So if you ever see disappearing vision or kind of a blacking out of the vision or kind of a red in your vision from a hemorrhage, then you need to make sure you're seen right away. Next slide. So I think I talked about this before, that cataract is when the lens in the eye becomes a little cloudy. Diabetics are actually 2 to 5 times more likely to develop cataracts, but they can also be caused by just normal aging of the eye, damage from the sun, trauma, steroid medications. So, rule number 1 is just to make sure that your blood sugar is under good control, and to, of course, wear sunglasses when you're outside. It's a very easy, basic thing that, we all should do, actually, when we go outside. And we talked about this before as well, glaucoma, usually painless, and you see the statistics at the bottom, when you have diabetes, it nearly doubles your risk of having glaucoma, unfortunately. So this is a very kind of important component of the eye exam that we want to definitely make sure we check the pressure to make sure that's under a good level as well.
Well, Dr. Hosmane, thank you so much for, I know I was just going through your website, so in case my eye was going back and forth, my eyes were kind of going, oh, I don't have my glasses. So you said
you can see really well still, though.
So it's just like the reflection that I didn't want to have, so otherwise but patients can reach out to you from your website. Now, we have a couple questions. Some of them we have on our presentation, so I'm gonna bring this up again. All right, so the one of the most difficult one the patients are having issues with, because diabetes and the eye exam actually is part of the quality metrics that we are being judged based on so many different insurances. I think it's the lowest score that we get, and then that's also same for the peer. Now, what is the reason that people wouldn't take care of their eye, especially when they have diabetes and especially they have these risk factors? Why do you think they are not actually taking care of this?
Well, I think most of it is because if they feel that they can see okay, they don't think that there's anything wrong. So I think we have to emphasize that there's still a potential of something going on in the back of the eye, even if we see okay and even if we're functioning okay. So I think it's one of the things that people just tend to kind of either not think about or kind of, just put off, and kind of other things just become more important.
So I'm going to go to Dr. Ciavarelli and Amy and Don. You guys can always jump in if you would like. Now, if the patient has diabetes and if they have feet problems, like how often should they see you, or how often they can see you, Dr. Ciavarelli?
So, like I said, the American Diabetes Association recommends that all diabetics see a podiatrist at least yearly. It doesn't always happen, you know, much to what Dr. Hosmane was saying, that oftentimes people feel okay, they don't feel like they have any problems, and so they may not, you know, come in, but it is really important, even if you feel like you don't have any problems, to come in at least yearly. People who have fairly well controlled blood sugar and no complications can, you know, come in yearly or twice a year. And then people who have, you know, a lot of risk factors, so they have circulation problems, and they have diabetes, and they have neuropathy, so that loss of feeling, those people are going to be coming in about 4 times a year, so about every 3 months.
And before the patient leaves your offices, you are already putting the return to the office orders, I believe, anyway. So that helps. But do you have similar problem that we have with the eye, where patients are not following up as religious as they should?
Oh, God.
No, go ahead. Is that a question for me? Sure.
This is for Dr. Ciavarelli.
Okay,
Like, on the eye side, we have, like, this is the nationwide problem. So, in fact, that we were just, Don and I, we were just having a meeting with Southside Family Practice, and we were trying to see what we can make, how we can make this easier for eye exam I'm talking about. So, but I don't know if the podiatry is having those types of issues in terms of the compliance from patients.
Well, I have to give a shout out to our amazing patient population. I have to say, you know, we have a lot of compliance. I have a large proportion of my patients that I see every day. I've been seeing every 3 months for many years. People come in. Now, they might be motivated by having care, so it's not just an exam, but we're typically trimming toenails and calluses and things like that that do need to happen in a podiatrist's office. If you're diabetic, you shouldn't be cutting your own toenails or dealing with your own calluses. So that might be part of it, but you know, I have to say, really a big shout out to our patients. They really do come in and get the care that they need for the most part.
I'd like to chime in there. I'm sorry to interrupt. And I apologize that I'm frozen. My screen is frozen. I don't know if you want to take my picture off, but I have a question for Dr. Ciavarelli. And with that, if you can just not look at my screen, or Kamal, if you want to turn it off, if it's too distracting. Okay. In our diabetes class, when we talk about foot care, we talk about no routine soaking, no sharp instruments on your skin, making sure you don't walk around barefoot, and having your toenails cut. And my younger patients in their 30s and 40s will often say, well, what do you mean, at the question that was up there about a pedicure? And, well, I'm only 35 years old. Do I have to go somewhere to cut my toenails? Because that's an old people problem. And so I usually refer them to their podiatrist to have that conversation. So do all people with diabetes need to have their toenails cut by a podiatrist?
So that's a great question, and it's a little tricky because the American Diabetes Association and the American Podiatric Medical Association, so the podiatrists, we all recommend that that no diabetics get pedicures. So, and by a pedicure, that means in a place where you're going to have someone who is not a podiatrist to perform care. And that is not to disparage our friends in the beauty industry, but you really, as someone who is diabetic, you have a risk of developing an infection. And that risk is just too great to take. As far as having someone who's 35, I would say send them to the podiatrist, let them be evaluated. and then let them have a conversation with the podiatrist about what's going on. I think that we have to remember that a whole person living a whole life is really important. If somebody is 35, has diabetes, has excellent blood sugar control, has no neuropathy, no circulation problems, then that's a conversation that they can have with their podiatrist about how to safely do some self-care, or if they need to come in.
Okay, great. Oh, good. Thank you. I'm glad I'm sending them to the right place. So that's
definitely, good. Definitely.
So, Dr. Hosmane, the eye side actually is one of the highest risk from the COVID-19 standpoint in terms of the infection. So, how did this change, the COVID-19 change your practice? And what do you have in place? What precautions do you have in place for the COVID-19 to perform the eye exam?
So, back in March, April, and May, I had to really limit a lot of the care that I was doing. My office was open, but I was really open for true ocular emergencies. But as of, mid-June, we're kind of back up and running. But we've had to make a lot of changes. So we do screen our patients ahead of time. So we either will give them a questionnaire over the phone or when they come in, about their COVID symptoms. We have everyone wear a mask. We are taking temperatures. And in our waiting rooms, we do have dividers up, so we don't have a lot of people, crowding the waiting room. I'm also kind of spacing the exams out a little bit more so that we don't have too many exams back to back, because now we have to, of course, disinfect all the equipment, between each patient. I also have shields on all my equipment, so all my equipment has barriers. I'm wearing mask, of course, and eye protection. I have gloves, and our staff is very vigilant about cleaning everything in our office, in between patients as well. So that way patients are reassured. I know a lot of folks are still kind of hesitant to come in, and they're kind of still nervous to come in. And rightfully so, but I think I have had patients where once they call us, they do feel a little bit better about coming in. We also actually have filters in every room as well, air filters as well.
So I have, guys, you can jump in if you do have any questions, but I have one question for another question for Dr. Ciavarelli. So every meeting I talk about my mom. So if this wouldn't be an exception if I don't. So. Now, one of the issues that she had when, I got her some diabetic shoes, she hated them. So, and she has diabetes, and I think we are controlling now a little bit better. And now, Amy, to your credit, like my knowledge base actually increased a lot on diabetes since we started working together. So, then everything that we learn, of course, we try to force the family members to follow. So then mom is now actually in better care now, but she hates the shoes. What can we do, or do you hear this from your other patients? How can we actually make this more pleasant for them?
I'm so sorry your mom hates her shoes. That's terrible. Definitely diabetic shoes have had a sordid past. I've heard Frankenstein shoes, and we've definitely come a long way. For Medicare beneficiaries, there is, if you meet certain criteria, so if you have neuropathy and so loss of feeling and loss of circulation, and you're under the care of a general practitioner, then you likely could qualify for the diabetic shoe program. Other private insurances also qualify for this. We use a company called Dr. Comfort that has a wide range of shoes that people can choose from. Actually, there's a really cool winter boot that looks really neat. I don't know if your mom would like it. We have sort of a Mary Jane. There's a lot of options, so we've come a long way. But definitely checking out the Dr. Comfort Diabetes Foot Care. I think they have some options that are also available online.
And in follow-up to that, what about sneakers? Are there any brands of sneakers that they can wear that are better than others, especially if they're walking or trying to do other active, types of things, maybe not running, but walking or any other type of exercise?
Yeah, that's a great question. I mean, obviously, we really want to encourage our diabetics to get as much exercise as they can. One of the brands that I really like to recommend is New Balance. The reason why I recommend New Balance is because they have standalone stores. And a lot of these stores are staffed by podorthists. So these are people that are specially trained in shoes, and they'd be able to make certain recommendations for someone. So if you go in and you say, I'm a diabetic, I'm looking for a new pair of shoes, regardless of what kind of shoe you get, if you do get a new pair of shoes as a diabetic, you definitely want to sort of give them a little bit of a test run in the house, maybe wear them for an hour or two, and then look at your feet and make sure that they're not causing any blisters or anything that you may not be aware of before you go out and do that big hike.
All right. Well, guys, I know it's late night, and except Donna and myself, you guys do have small kids. And I do really appreciate for this. This is a really great opportunity for us to have this discussion and make this available for our patients, for you guys, for our providers to be part of this. And Amy, Donna, you guys are doing a great job. I think the diabetes is extremely important and extremely complex illness, and if we can put the education out there and make the resources available for our patients, that's kind of what our goal is. And we are doing this for our existing patients. There's no financial motivation. We just want to make sure that these lectures are available for our patients. So, and I do really appreciate for you guys taking your time and joining us. Do you have any questions or any last final thoughts?
I just want to say one quick last thing. It's interesting because the patients that are coming in, there's a lot of dry. Everyone has dry eye, but unfortunately, because of everyone's wearing a mask these days, we actually have more dry eye because of that, because the air is kind of being pushed upward. So I think a lot more dry eye out there. So I think I definitely have a conversation about dry eye and what we can do to kind of help relieve that, a little bit more. So it kind of ties into COVID, unfortunately, as well.
Amy, Donna, Dr. Ciavarelli?
I don't think I have any other questions, but we do greatly appreciate both of you joining us. We feel this is important education for our patients as well, and it is recorded, so we have it out on our website, and they can go out there. So any of your patients that you'd like to refer to the UMACO wellness page, that way they receive all of the updates about all of our different events, and Amy posts out there several times a week. And we'll also be asking you if there's any small posts that you would like to send to us, and we can also include those on the page.
Thank you.
Next event is going to be on the 23rd, I believe, right?
Yes.
Yeah. So, and then those updates will be on our Facebook Live and Facebook page. And also this Friday, any of our patients are following this right now. We have an event on Friday that I do weekly, and I will have one of our cardiologists, Dr. Gary Singh from Delaware Cardiovascular, joining me. And that's going to be a Facebook Live event at noon on Friday. Otherwise, we'll see you all on the 23rd of September. Thank you again. Thank you so much.
Thank you.
Thank you.
Thank you.
Good night.
Good night.